Hello, welcome to the Essentials in Robotic Surgery, How to Get Started. This evening, we will go through the introductory skills for robotic surgery, tips for getting ready for robotic procedures, and what is needed for specific programs and the main tips for each subspecialty procedures. The current evidence for robotic applications in oncology surgery. We have a fantastic international panel of experts for this evening's session, which we have carefully selected to give different perspectives. So by the end of the webinar, you will know the basic introduction to robotic surgery, know about the examples of robotic surgery in relation to upper GI, colorectal, hepatobiliary, and know some evidence base around the robotic surgery. Please note there is a Q&A after some of the sessions, but mainly we keep all the Q&As to the end. So I suggest that during the actual talk, you use the Q&A function to actually ask the questions. And in some cases, we will answer it live. And in some cases, we'll have a discussion at the end. So please do ask the questions as we go along. There'll be some suggestions and some extra information popped in the chat for yourselves. So please keep an eye on that. And first of all, we will start with our first presenter, which is Ruth. And Ruth will be presenting the skills introduction to robotic surgery and how to get started with robotic training. She is currently Senior Clinical Fellow in Hepatobiliary and Transplant Surgery at Leeds Teaching Hospitals, UK. She finished her training for general gastrointestinal surgery and CCT'd in Barcelona, Spain. Her field of interest is liver transplant and HPB surgery. So over to you, Ruth.
Thanks very much for the introduction, Dr. Elanko. Can you see my slides? So I'm going to briefly introduce which skills are related to the robotic surgery and how to get started, especially for the early career and trainees and residents that are interested to get involved in this kind of approach. I have no disclosures. So I will try to cover the concept of robotic surgery and also get started, what and where you should train. As a background, we have that robotic approach is becoming more common nowadays, especially for oncological cases, and we expect to be seen even more in the next few years because there is more systems available now in the market, and therefore the cost should be better in the next few years, and the same for the access. Starting in a robotic program or gaining skills, surgical skills in the robot are key for those who wish to push your career in robotic surgery in their subspecialties. For those who have not been able to have access to robot, just a basic concept. In a robotic theater, the robot has different parts. You have the arms on the patient cart, that is the part that it has access to the patient. There is a surgeon console where the surgeon performing the surgery sits and manage to control these arms on the robot. And then there is the vision card, just the screens where the assistants and the full team can also have a view on what's going on inside of the patient, like for a laparoscopy. Comparing to other minimal invasive approach, robots have allow us to have a 3D view, which is better in terms of dimness and have a better view compared to laparoscopic systems. Also allows a greater range of motion because the instruments have a breast action simulator, so allows the twisting like a breast, so it's easier to perform different steps in the surgery compared to laparoscopy, like for example when you are stitching. And also the precision, because it removes tremor, for example, from the surgeon. So these are the main difference compared to other minimal invasive approach. In terms of skills, it's quite wide. You can have previous skills in general surgery and other minimal invasive approach like laparoscopy that can be used. as part of the background for robotic. There is some technical knowledge that is specific for the robot, like how to manage the console, how to place the chokers, or the patient card, how to place it for different procedures, depending on the anatomical area as well. And there's also the non-technical skills that are important, because we need to understand that this happens in a robotic theater, in which, for example, the main surgeon doing the surgery will be in a console that maybe it's on the corner, it's not next to the patient. So it's very important also the communication, the teamwork, and how all this team works together to perform the surgery. So in terms of how to learn or how to get these skills, there is different steps, but I will say that it could be divided in 3 parts. The first part would be the patient side training, how you position the patient, how you perform the pneumoperitoneum, or basic things like port placement or jockeying with the robot can be gained by giving assistance or doing observership in a robotic theater. How to manage the console and how it works is something that you can learn by simulation, and also because there is many courses in which you can practice in dry and wet labs with cadavers and anatomical models, and also taking part of a procedure, being supervised with a senior experienced surgeon, performing initially some steps of the surgery, and later on gaining more experience. And this is part of the learning curve. So ideally, this should be happening inside of a structured training program, like, for example, inside of a robotic fellowship. But this is not happening with all subspecialties, because it's more common with some of them, like colorectal, urology, that have been using the robot for longer time. Also, the concept of the proctorship, that it's performing the surgery being supervised by an experienced surgeon in robotics, and the concept of starting by simple cases and gaining experience until you reach to be done complex cases. There's many different systems right now. All started with the Da Vinci from Intuitive. By now we have the Hugo from Medtronic, or the Versus from CMR Surgical. So we expect to have more availability of robots in the future in the theaters. For those who are starting to get trained and want to know how to take off in the robotic training, I will try to answer some questions, like when to get started. There is no ideal time for get started. I will say that the sooner the better. So if you're a trainee or resident that can get exposure to robotic in your center, that would be ideal. But if not, you can perform this as a fellow in robot, or when you are a consultant, get trained as well in the robotic approach. So you are always on time to get trained. This is an interesting study from ACID, that is the Association of Surgical Trainees here in the UK, in which they survey some surgical trainees, and what they saw is that most of them would like to get trained in also in robotic surgical approach. And when they were asked about how they see robotic surgery, they see that as a future, as something precise, innovative, and the main disadvantage for them will be the cost, and the access to the robot. This study, for example, comes from the States, and it's quite interesting to see how this is adapted to every single year of training. Here, the general surgery training is 5 years, and we see that in the early years, first and second year is mostly observation. For the intermediate years is the assistance in the bedside, and only by the latest senior years is when you can get access to perform surgery as the surgeon in the console. And the ideal procedures to get started are simple ones, the same as when you are trained in general surgery, like cholecystectomy, hernia repairs, colectomies, sleeves. For those thinking that maybe this can have a detrimental in the learning in other approaches, like open or laparoscopic, this is an interesting study as well from the States, in which they compare the activity in the previous years. And what we see is that the activity for open or laparoscopic doesn't change at all. What it increases is the activity in the robot. But this is something to take into account, because it's important to get trained as well in the other approaches. In cases that you are not able to complete the surgery by the robot, you should be able to do the same in open, for example, if there is any complication. In terms of cost effectiveness, this study compared cholecystectomies and hernia repairs or simple cases with robot and without robot, incorporating their residents in the training, and they weren't seeing any difference in terms of cost. In terms of where to get trained, what I will say is you need to get trained in a center of reference with experienced surgeons that can provide mentorship and proctorship. This is really important, and ideally inside of a robotic program with a curriculum in training, and taking into account the learning curve in which the different steps happen, and the more cases you do, the better you become. And starting by simple cases to be able to perform in your later stages complex cases. In the robot, the good thing that we have is the simulation, because in some consoles of the robot you can do simulation, but also there is some platforms that allow simulation in as a robotic approach. This increases the surgical skills in a controlled environment. So you're able to improve your technique by correction, different models, and repetition, because it gives you your score, so you are able to repeat and learn from your mistakes. This is compared to aviation. At the end of the day, it's like flying hours. So the more you train, the better you become. And this is in benefit of your future patients. And it's not only simulation. If we see different ways to also get access to skills and learning. There is workshops, online training, courses by the industry, but also by the associations in different super specialties. So nowadays there is many ways to get trained. Another thing that I would say that it's very useful when you are looking for a center that it's training residents or fellows in robot approach is the dual console by Intuitive that allow simultaneous access to the patient control by the lead surgeon and the one who is being trained. So the surgeon can take control of the operation at any point, or can help to indicate which steps should be doing or how to correct to do something. So this is very useful when you are training. In terms of what resources we have, there's many books in terms of theory of the robot and how to perform surgeries, and also many videos online. There's stages, Atlas is really good in terms of covering general surgery procedures and some tips and tricks. Da Vinci platform also have the learning models in which you can get access to the main things when you are starting to learn how the console works and how the robot works in terms of port placement, how the patient card works, the docking, the instruments, the console, and also the troubleshooting. And this is for free. And at the end of the training, you have a certificate, so this is good. But I would say that at the end of the day, this is only theory, so you can't try this at home. You need to get trained further, and the way to get trained further is specific courses. For example, there is courses from in here in the UK. We have Newcastle Surgical Training that offers every year different courses on cadaver model for hepatobiliary, for colorectal, for many more, and abdominal wall, for example. In Portsmouth as well, we will have Professor Khan speaking. They have done many courses regarding basics of the use of the robot and many more in colorectal. And also in France, we have IRCAR, and in Belgium, Ortho, that provides different courses in different specialties in the robotic approach, and that can be helpful when you are seeking a specific training in your specialty, but in this approach. Also, I will recommend to review your different associations. In this case, for colorectal, that it's further exposed. The European Society of Coloproctology offers opportunity to learn under a fellowship, and also different webinars and different learning materials that are in their own website. So this is really helpful. And just to summarize, I would say that this is the future. So we need to standardize a curriculum in the robotic training, and it's not always easy and not always well developed in each specialty. There is no specific time to start learning the robotic approach, but the sooner the better. Ideally, this should be done in a experience center under the supervision of experienced surgeon in the robotic approach. And the more you train, the better you become. So this is the way to get to the excellence as a surgeon. And here the only limit is you. So the more you train, the better. And I would like to finalize with a quote from Steve Jobs that I think it can be extrapolated to the robotic approach as well. He said that the technology is nothing, that what it's important is that you have a faith in people and that they are basically good and smart. And if you give them tools, they will do wonderful things with them. And this is what happened with the robot. It's not the robot doing the surgery, it's the surgeon doing the surgery using the robot. So the more you train and the better you understand these systems, the better you become as a surgeon and the best outcomes you can get with your patients. So this is quite extrapolable to the robotic surgery, I would say. Thanks very much, and I will answer any questions at the end of the webinar.
Thank you so much, Ruth. That's a really wonderful presentation. I'm really grateful for that. As for the attendees, please do ask any questions in the Q&A session, and we will try to answer as many as you can. If you are struggling with that, you can always put them in the chat function. We are monitoring that as well. Now, our next speaker is Professor Jim Kahn, who's going to speak on robotics in colorectal surgery. He's a consultant colorectal and minimal access surgeon from Portsmouth in the UK. He's honorary professor of surgery at the University of Portsmouth. He's the clinical lead robotics in robotic surgery and program director for TME fellowships. Professor Kahn has been a national trainer for laparoscopic colorectal surgery and European proctor and trainer for robotic colorectal surgery. His research interests include clinical research in robotic colorectal cancer surgery, complete mesocolic excision for colon cancer, quality of life and functional outcomes for low anterior resections, training in laparoscopic and robotic colorectal surgery. So we're really looking forward to your talk, Professor Kahn. Over to you.
Afsana, thank you so much for a very generous and kind introduction, and good evening all. I will start sharing my screen first of all and see if we can make it work. That's looking good. And I do hope that you can see my slides now.
Yes, we can.
Yes.
Yep. So I'm going to cover a little bit about, I think the scene has been set very well already about basic robotics training, where to start as a trainee. And I think what I will try to give you is a flavor in colorectal, which is my area of interest of where robotics is going. Obviously, various specialties have different lead time in robotics. Urology started it very early, then colorectal jumped on. Gynae got involved, now upper GI, liver, hepatobiliary, all of us are kind of in this journey together. So sharing my experience over the next 15 to 17 minutes. This is Portsmouth. Many of you would have been with us on some various courses and various training events that we run. So you're very welcome to join us for basic or advanced robotic courses and events throughout the year that happen. These are my disclosures. Now, question I would ask is that, is robotic approach really better over the conventional ways of operating? And I would say that robotics is a technique pretty much onto that. I love that last slide of Steve Jobs, that it's a tool, and technology and tools are only as good as the person who is using them. So first of all, it's not a shortcut to not learn something properly. So you need to have a good understanding of the disease, the pathology, the way you manage it. If it is oncological procedure, how do you do it? And then use the technology wisely in order to make your journey and job a lot more easier. But then you start exploiting that technology and you can start extending those benefits to a bigger group of patients. And again, you start learning, is it easier to learn? Is it easier to teach? And are you benefiting a lot of your patients? Now in colorectal, obviously this is an oncology webinar, so we're going to be focusing on rectal cancer and colon cancer. And I think if I talk about rectal cancer for us as surgeons, it's very important that we look at local recurrence rates, we look at patient survival, but more importantly, quality of life for those patients as well. And over the years, we have seen approaches change from open to laparoscopic to single port, and more lately, robotics. Patients are getting older, so we have a population which is now going to be a lot more older, a lot more frail. Sometimes I'm in clinics and I look at these patients, I think I'm doing a geriatric clinic because everybody is over the age of 80 and nobody wants to to die, and they all want surgery, and then nobody wants a stoma. So how do you manage those kind of expectations? This is a 90-year-old lady who having a rectal cancer resection with us, and then the key is, can you get her back to independence? Can she live alone the way she was managing beforehand? And there are some real challenges, and I think we are going to get into this patient-centered, tailored approach of these cancers, and using the technology wisely where it helps you. And I think robot in that sense is a tool which adds on to precision. And precision for surgeons come from imaging. You have good quality MRI, PET-CT, 3D reconstructions. You have now precision surgery with robotics and the vision that you get and the access that you get. And then when you're doing oncological procedures, you're looking at the margins, the lymph nodes, local recurrence rates, and the morbidity of those procedures. We do know that laparoscopy is well established, but it does have its challenges. We have high BMI patients, we have difficult ergonomics of laparoscopy, so bulky tumors in a narrow area can cause significant limitations, and we end up having high conversion rates. This is the UK data for rectal cancers, and if you look at it, the blue bar, the deep blue bar at the top shows you the number of operations done with open approach. So you can see that there is significant number of rectal cancer surgeries still done open. And although I agree that not all rectal cancers will become robotic, but there is a room for improvement there. The gray bar shows the number of conversions happening in laparoscopy. So you can see that in spite of having very good laparoscopic training, we still have a high conversion rate. And most of it is due to technical challenges and limitations that we have. Now, if one slide can sum up the benefits of robotic surgery, that will be this, where you can see the 3D view of the robot, the stability of the camera, the ease of access with the end-of-wrist instrument, scaling down your movements. And now you have table motion where you can move the table around and be able to see gravity help you in terms of complex cases. The two last points on this slide, which is the nerve preservation for the patients, because you can see better and you can do nerve preservation procedures, and the ergonomic impact on the surgeon from the stress of doing laparoscopy and long procedures is underestimated in many, many studies and many assessments. I think it's very important, both from the patient and clinician perspective, that you perform surgery in a more stable, settled, controlled environment. And those specialties such as plastics, or neurosurgery, or hand surgeons who do precise surgery prefer to sit down and perform controlled operations. This slide just gives you how robotics is expanding, and those of us around who are thinking that robotics is not something that we should think about, have a think again, because the global market of robotics is just going to exponentially expand. The predictions are that by 2030, we're going to have $25 billion invested in robotics, in surgical robotics I'm talking about. So, and if you look at the rate of growth in this is phenomenal. So there used to be one company. We heard that there are 3 or 4 companies. I can tell you there are 15 other companies in the background working on various robots in various platforms, and they're going to make surface the market. And what it does, it drives competition, it drives the prices down, it drives innovation, and it becomes a method of operating. If affordability was not in the equation, I would say nobody will say no to robotics. It's the moment is the lack of access and the price, which will get better. I'll go through this very quickly because we know the benefits of robots, but there are some limitations. Sometimes we have limited space, you have limited range of motion sometimes, you have lack of tactile feedback. Sometimes you need a team around you to be able to dock the systems and operate in a proficient manner. And if you don't have that, it's going to balloon your operating times. So you need to have proper setup, proper kit, proper team, and it's not a one-man show. So you need to invest into that peripherals to make this a viable option in your setup. And the cost obviously is always a major drawback at the moment. Still, you have to prove the cost effectiveness of robotics. Now, for us as colorectal surgeons, these are the main benefits of the robot, where better vision, operating in narrow areas, identifying key structures such as iliac vessels or ureter, and working on large tumors, and the ability to operate in high BMI patients leads to low conversions. And we all know that conversions are bad, because when conversion happens in minimal access operation, it leads to poor outcomes clinically, depression and disappointment for the surgeon, increased cost for the healthcare when we are having a treatment. and also poor oncological outcomes. If you look at those patients who get converted, do worse as opposed to those who have a successful minimal access operation. Now, obesity is a major issue. We have no real guidelines around minimally invasive robotic procedures in high BMI or obese patients, but these are the national, international guidelines around the world from ESMO and NCCN, and you can see that the obese patients acquire a higher level of skill set and technical abilities from the surgeons, but there's no comment made on how robotics can make surgery in obese patients easier. This is the UK map. It's a 10 years old map, but it shows the orange counties are the counties where 1/3 of the population is obese. And if I repeat this map now, I'm sure it has kind of intensified over the last 10 years. So we're all going to be dealing with patients like this, who have multiple procedures, multiple laparotomies, high BMI, or this, where the BMI is 65, young chap with a low rectal cancer, and you cannot bring a stoma out for this patient. Even if you want to do a colostomy or a stoma, you just cannot do that. And you have to find different ways of dealing with the situation. Robotics offers you advanced instruments, and there are various kind of advanced instruments like energy devices, like the one in the middle called vessel sealer, stapling device that you can use in the lower pelvis or in the esophagus in the difficult to reach areas. And then we have a couple of examples of these advanced instruments here. You can see a suction in my left hand using in the deep pelvis, operating with the scissors and using the suction, which is controlled by the robotic arms, allows you to operate in a narrow area without any smoke in your view, and you can have a very precise, clear view to operate. If you look on the right-hand side, you can see a harmonic type instrument, which is called Synchroseal. It's a bipolar instrument, but very thin, curved blade. You can get into narrow areas on top of major vessels. This is a dissection being done in front of IMA on the left side to preserve the left colic vessels. So you can be precise, you can be pretty bone dry, and you can have much better view by using some of these instruments in the deep pelvis. Then comes the navigation, and that's very much of an interest for me, because I think for surgeons to have this ability to see structures and have the ability to be able to navigate in the pelvis, I think robotics lends itself very nicely as a framework to employ intraoperative navigation, image superimposition, and real-time mapping. And I might show some of that in a minute. For rectal cancer, for example, our port placement is very standard. You can have a linear port placement on a line with 4 robotic ports, and you have 1 assistant port. So with that arrangement, you can reach the pelvis, the left iliac fossa, and the left upper quadrant as well. And then some clips of how we do it. You're sitting down on a console. You're operating in the pelvis. You're doing a total mesorectal excision. Let's say for rectal cancer at the back, you can see the right hypogastric nerve there. And you have these endowrist instruments which allow you to operate quite precisely. You hardly see a drop of blood because you're absolutely staying in the normal anatomical planes. And when you're not crossing planes, there are no blood vessels to go through, which means that it's an absolutely dry plane to operate, minimal bleeding, great views, and you can do nerve preservation and a good oncological cancer resection. Now, stapling, we saw that earlier. So how does that stapling work? You go deep in the pelvis. You have this endowrist rotational action on that stapler. You can use fluorescence imaging to make sure that there is good quality perfusion, and then use that stapler to go across. This is a division of the rectum on the pelvic floor in a narrow pelvis, and you can see how nicely the stapler goes across the rectum. In 1 or 2 firings, you can have a complete cross-section of that. And that has really been an added value to us as colorectal surgeons to be able to control that safely and dissect that rectum quite nicely. Now, dual console, again, I call it like learning driving. So you have none of us learn driving without having a dual control in a driver's learner car. So here we learn surgery with single controls, but a dual console is almost like I have a master controller and my trainee or fellow can perform on one console, and I can take over control of one instrument or all the instruments if I want to, and I can give it back and forth between both of us while we both have a same view and same access to the patient. So it's a great tool and resource to use for proctoring, training, and learning complex operations or operating together as a different specialty on complex operations. In colonic resections, it has been limited use so far because of the limited number of systems and lack of perceived benefits in colonic surgery from the robot. But if you look here, this is the way we do all the abdominal surgery for us nowadays. So suprapubic ports, 4 ports in the groin crease, and you can reach the whole of the abdomen, right and left, and perform total colectomy, segmental colectomy, anything that you want to do. That's the port placement that you will use for abdominal approach to all of colonic cancers. And what we do is a CME dissection, which is called complete mesocolic excision. So here you see a different instrument like a hook being used with a robot, and the vein on the floor is the superior mesenteric vein. So you expose that vein completely, you skeletonize that, and take all the vessels of the right colon as they come off this vessel. This is the ileocolic vein joining the superior mesenteric vein there. The thing to appreciate here is the precision, the ease of access, and the accuracy of your movements that you have. Everything is stable. It's a slightly higher MI patient, but you can still expose these vessels quite nicely. It's again the same concept, avascular plane, hardly any bleeding, and you're working on major vessels without the risk of bleeding. On the right-hand side, you can see the picture where there's a pancreatic or duodenal vein and a colic vein and a Henle trunk exposed at its junction with the superior mesenteric vein. I never saw the images like that in my laparoscopy practice, but robotically, I am much more controlled. I have much more stability on many of these difficult areas when you're operating. And then comes these kind of dye assessment with ICG, that you can inject the dye and look at the perfusion of the bowel or look at the drainage of that into the lymph nodes. So I wouldn't have time to go through all the videos in detail, but these are the kind of procedures where robotics adds a lot more value to do more radical lymph node dissection and radical right hemicolectomy with intracorporeal anastomosis of the bowel, which could be hand sutured or stapled, and then everything is done from suprapubic ports with minimal pain and trauma afterwards. And what does the data say about it? So we looked at our own data. We were good laparoscopic surgeons, and then we changed the approach with robotic CME. And you can see this is a propensity score match analysis that we published in BJS a few years ago. You can see the lymph node count doubled very quickly, significant difference there in the lymph node yield of these patients. And then the specimen was much better quality with higher significant size in the CME operations done robotically. But importantly, the survival, when we look at the cancer survival in these patients, we are beginning to see the two Kaplan-Meier graphs separate quite substantially. For overall and disease-free survival, there is a difference in our hands between a CME operation done, as I just shown you, versus a standard of care procedure done laparoscopically. And then again, I will quickly skip to some of these slides for more advanced indication on the lateral pelvic sidewall. We're doing sidewall dissection on the obturator nerve, internal iliac vessels, superior vesical vessels. Here again, you can have the same approach into narrow areas where the tumor tissues can be excised with good precision. It's an interesting case, young lady who was referred to us after 2 years having an anterior resection, and she's got paraiotic nodal disease going into the kidney. You have the 3D reconstruction. You can see how the aorta has been splayed to the side with this mass sitting between the kidney and the aorta, involving the renal vessels on that side. Again, we use the same 4-port techniques with a robot, and as you see, we go in, there is some scarring from previous operations, so we have to excise everything in front and to the left of the abdominal aorta. And I think for the sake of time, I'm just going to show you something here. This is the inferior mesenteric artery, or the remnant of the inferior mesenteric artery over the aorta, which is kind of skeletonized and taken. And then the interesting thing here is that this is once it's done. And if you look at here, the abdominal aorta is kind of retracted medially, and this mass, which is lifted up on my left hand, is the whole nodal mass. And you can see how much of the aorta we can roll towards one side and work behind it in terms of separating from the vertebral bodies. And these are the kidney vessel or the renal artery on that left side coming out. So you can do more advanced, more complex resections that otherwise may have been impossible. And the last thing I want to share with you is this hot of the press AI-based navigation for surgeons. So again, we're using robotics, TME surgery, but you're using machine learned algorithms using a protocol to identify connective tissue and nerves. So the color coding that you're seeing is coming from our AI algorithms telling the surgeon where the dissection plane may be. It's an aid for the surgeon. It is not the end result, but you can use it to follow the dissection plane. And if you're lost, you can switch it on and off to look at real-time intraoperative navigation for the surgeon while looking at a complex procedures. So What does the data suggest around colorectal cancer? We have reduced the conversion rates with robotics as opposed to laparoscopy. Multiple studies, case control, cohort studies, some systematic reviews and meta-analysis. One thing consistently comes up that you reduce your conversion rate in MIS surgery if you use robotics. What are the oncological outcomes? There are again multiple data. ROLAR is the only randomized control trial. They haven't published the long-term data, but from the case control studies, multiple studies looking at 3-year disease-free and overall survival, showing at least parity with laparoscopy, if not less. In fact, my own experience is that we have improved outcomes and improved survival, but if you generalize it, it's still equal to minimal access approaches used otherwise. That's my own data that we published in Annals of Surgery. And if you see the graphs here, there's a statistically significant difference in 5-year survival for rectal cancer done robotically versus laparoscopically. And that's the first study presenting 5-year follow-up data after robotic surgery for rectal cancer. Nerve preservation is difficult, but we all want to improve better function for the rectum and the colon and the bladder. The studies show some improvement of nerve function because you see the nerves better and you have a less risk of damaging them. So I think I will not have time to go through ROLAR trial results now because I'm out of time. So I want to skip these 2 trial slides. ROLAR and REAL trial are the 2 trials that are out there. So if you're interested, have a look at those results. But I'm sorry, I have gone over time. I will start to bring it together by saying that robotic approach is rapidly growing. There are new platforms introduced and the data is growing with evidence to support the use of robotics in order to improve outcomes of these patients. And if you want to hear more about this, or you want to see some of this in live action, be glad to host you in Portsmouth next year in June, where you can see this in real life over the 3 days period of the Congress. Thank you very much for your attention.
Thank you, Jim. That's really good. And if you go to the Congress, you can also do the robotics course, can't you, Jim, beforehand, and then do some in person. So it could be quite a good learning experience. Now, Jim, we have a few questions from speakers here, sorry, from the audience, if you don't mind answering at the end of yours talk. So how long is the training curve for robotic surgery in colorectal? Hence, most of the procedures requiring precision, skills, and experience in training.
So interestingly, the learning curve, if you ask about colorectal, depends on your starting point. So if you're an established surgeon already doing laparoscopic practice, the transition from laparoscopy to robotics is quite quick. You're talking of something between 20 to 25 cases by the time you learn how to operate the robot and how to change your technique a little bit. But if you're an experienced MIS surgeon, that switch is very easy. But if you're a trainee coming through training and you're still not proficient in laparoscopy and you're going to go onto the robot maybe earlier on, it might take you a little longer. You might double that number. So many studies present a learning curve figure of 50 cases or 40 cases on the robot to become proficient. But I think learning curve is very arbitrary because you're going to go through various learning curves. You will have a first learning curve for the first 20 cases when you're learning the machine. You're very super selective in how many cases you do on the robot. And then you get braver and then you start taking more complex cases on. And then you're going to hit a second learning curve when you're going to do more complex cases and have some more complications, have longer operating times and gradually get better. And then the third learning curve will come when you start training somebody else. And of course, you then have to bear the discomfort and pain of taking somebody through that and still improve the outcomes and keep your operating time slower. So these things change over time, but the actual transition is pretty quick.
Thank you, Jim. So the next question I have is, obviously, thanks for the presentation. How do you mitigate nerve or compression injuries during the operation?
That is a very important point, and I think this is responsibility for all involved in that case. These are long procedures, sometimes 3, 4, or 5 hours long, and a patient could be in one position because the robot, you cannot move the table that frequently. So you need to pay full attention at the time of briefing and team brief in the morning and the patient setup and how you position them and how you prevent them from slipping. So the hand positioning, the ankles, the legs, the beanbag mattress or anti-slip devices that you're using, you have to make sure that you protect pressure points and you make sure that there is no extra pressure on any of those areas. The calf pumps are on and in the right position. And then the frequent checks, because things can change. So every hour, somebody checks those positions that they're okay, and then have a time limit of stopping the procedure, leveling the patient, and giving a break, not only to the patient, but to yourself as well. And most surgeons will have a SOP in their practice of 3 or 4 hours of operating and have a break at that stage.
Mark, do you or Florian want to add anything to this question, because it's more generic?
No, I totally agree with this. It's a long learning curve, and it really depends where you start. And it really, I don't believe in specific numbers. How the learning curve should be this many cases or that many proctorings. It really depends on the trainee.
Okay, so the next question is quite topical, actually, not just in one country, but it affects all specialities and across different countries. The issue of medical litigation in case of robotic machine malfunction in the hands of experienced and skilled surgeons. So I think the question is, what if there's a malfunction in the machine and you're an experienced surgeon? What happens during litigation? Because this is a worry for quite a lot of people.
Who wants? Oh, that's my timer. I was supposed to stop that. I think I can just have a very quick comment, and we can hear from Mark and Florian as well. But I think it is easy to blame the tool. It's so easy to blame the tool in your hands. And I would say, similarly, laparoscopic kit can misbehave. You can have an instrument malfunction, whatever you're using. We saw a big rise in litigation in the US when robotics was rolled out. And there were lawyers out there asking that, okay, if you have your operation done by the robot, come to us, no win, no fee, we'll take your case and get you some claim money. It was so easy to do that because robotics got rolled out without any governance, without any guidance, and everybody sort of learned on the job. So these are sort of strong, powerful tools. If you give it in the hand of people who don't know how to use it, you're going to get some complications. And hence, you have to have a cover as a medical legal cover for your own self to say, what have you done actually to be able to do that? And there are some very good models around various institutions, industry supported models, various society proposed models. The basic concept is very similar, that you go through basic training, advanced training, wet lab, dry lab, case observation, and proctoring before you actually start doing something independently. So I think in real life, the machine malfunctioning and ending up in a disaster is very rare event. But what happens more often is the lack of knowledge of the machine, the lack of expertise, lack of proper training. And then when things go wrong, it's so easy to blame the tool.
Florian, shall I hand over to you next?
Yes, basically, I definitely completely agree with Professor Khan. So from my experience, which is somewhere in between 150 and 200 robotic cases now, I've never seen any real malfunctionings of the systems, and I've never heard of any. So we have to acknowledge that there are millions of operations already been done, and most of the issues that I've seen and the complications occurring intraoperatively were due to a lack of experience or just being not safe enough, and just underestimating the power of the tool. So I guess that's basically just a matter of training, and I don't think that you cannot trust the system.
Thank you. Mark, would you like to add anything?
Yes, nobody's perfect, and especially people that use the robot are not perfect. For esophageal cancer, where I'm a trainer in, we practice some emergency procedures as well during the training sessions in skill centers. And it also is part of the dry practice when a team starts in the OR. The first thing you want to know is what to do when a problem occurs. But in the more than 1,000 cases that I've done in upper GI surgery, I've never had to do a quick conversion because of the machine malfunctions.
Thank you. Thank you so much.
And it is a CE approved and FDA approved machine, just like a stapler. So, you know, legally with litigation, you have a certified machine that you're using.
Mm-hmm. So it's medically approved. Thank you so much, Jim, for your lovely talk and for answering the questions. And I think I need to move on to the next speaker. Thank you so much for that.
Thank you.
It was
My
really
pleasure. Thank you.
And we had a really good discussion as well, which is always very meaningful in these sessions. So our next speaker is Mark Bundet, who is going to speak on robotics in upper GI surgery. He is an upper GI surgeon working in the Netherlands. His field of expertise is gastroesophageal cancer, as well as benign upper GI surgery, including reflux, hiatal hernia, and bariatrics. He's done robotic surgery since 2015 and is a proctor and trainer for Intuitive since 2016. So over to you, Mark.
Well, thank you very much for the introduction. Let's see. Is everybody seeing my slides right now?
Not yet.
There we go. Do you see my slides?
Not yet, Mark.
Sorry. There.
Perfect.
So thank you very much again for the invitation. My name is Mark van Det. I work in the Netherlands as an upper GI surgeon in a small town called Almelo in the eastern part of the country. We have been doing robotic surgery since our XI system was installed for general surgeons in 2014, and I've been a proctor since 2016. I'm talking about esophageal cancer. And when you look at the data coming from the national databases, you can see that there is a big interest in the minimally invasive approach for esophagectomy. And this is minimally invasive versus open. And when you look at the Netherlands, you can see that the last years, almost nearly all the procedures in the Netherlands are being done minimally invasive. However, it's not 100% yet, and I think that there really should be a way towards that 100%, and I think the robot should have a function in that. In the year 2024, the year in which we live right now, the minimally invasive esophagectomy is still the cornerstone in curative treatment for esophageal cancer. And as surgeons, we all know that the esophagectomy is a long and also a demanding procedure in 2 cavities of the human body. It goes together with a lot of morbidity and even mortality, and still the oncological outcome is not excellent. So there's room for improvement. And the way I see the robot is the way I see these 2 cars. They're both cars. And when you have a nice sunny day and it's not too crowded on the road and the distance is not too long, it's very nice to have a nice old car to drive from point A to point B. But when you're in the middle of winter, you have to do a long drive and it's snowing outside and slippery on the road. It's nice to have a new car with new techniques like ABS, 4-wheel drive, cruise control, etc. And that's exactly what the robot means for us, for minimally invasive surgeons. Because the procedures that we do, it's not a different procedure. It's a minimally invasive technique. For esophagectomy, you can do a 2 or a 3-stage procedure, depending on where you want to put your anastomosis. It involves a gastric conduit, etc. But the instrument that we're using to perform the procedure, that has really been improved. And this is exactly the difference that you experience when you use the robot. You don't have to stare to a screen that's 2 meters away from you, above your eyesight, and you're disturbed by all sorts of other things inside the OR. You're sitting comfortably in your cockpit, and the only thing you see is your laparoscopic field, while you can still excellently communicate with your robotic team. So I think the value of the robot is in the very first place the improved ergonomics. And improved ergonomics for the surgeon and the OR team leads to several other things, like improved surgical quality. In our experience, we have a 30% higher lymph node yield while removing the same lymph node stations. We see more R0 resections, and we can extend our indications to try to achieve a curative treatment for our patients. And besides that, we can also see a reduction in our complications. In upper GI surgery, the number of lymph nodes that we remove is very much connected to the chance of survival for the patient. There have several trials been published that demonstrate the relation between lymph node yield and survival. And Therefore, I think that if we can remove the lymph node stations more accurately with a robot, it should lead to a better survival. That has not been demonstrated yet for the robotic esophagectomy, but there has been one RCT already demonstrating that a robot-assisted approach does lead to a better lymph node dissection. And also a shorter operative time, but that's out of this discussion, I think. At this time, there are 2 RCTs going on, comparing minimally invasive esophagectomy or the conventional MIO or MIE compared to the robot-assisted esophagectomy. These trials have not been closed nor published yet, so hopefully we will get the data shortly, especially the RAMI trial that's looking at 5-year overall survival. Should be very interesting to prove the benefit of the robot, which all of the users actually already know. When we look at our own results, like I said, we've been doing this technique since 2015. Obviously, we've had a learning curve. At that time, there weren't that many hospitals out there performing esophagectomies on the robot. We were trained by our friends and colleagues from Utrecht. And at that time, we started with a hybrid procedure, doing the abdomen laparoscopically, and then we did the chest robot assisted, and then the anastomosis in the neck. From there, we went to the hybrid Ivor-Lewis, doing the intrathoracic anastomosis, firstly hand-sewn, later with a linear stapler. And from there, we went to the fully robotic procedure that we started doing since 2016. Our national cancer registry for upper GI is called the DUCA. And when we look at complication rates in our own center, we are the blue line. And the gray line is the average result in all the 16, 17 other Dutch hospitals. You can see here the Clavien-Dindo 3 and higher complication rate in our series. And you can see that after our learning curve, our complication rates have really dropped to around 10 to 15% right now, compared to 10% higher in the rest of the country. When we look at anastomotic leakage for all our esophagectomies, so cervical and intrathoracic anastomosis combined, our leak rate has really dropped since we adopted our linear staplered technique in 2018. And right now we have had less than 5% leak rate since 2020, compared to still more than 12% in the Netherlands on average. When we look at the intrathoracic anastomosis, the Ivor-Lewis procedure, as we call it as esophageal surgeons, since 2018 we started to use our linear staple technique, and since 2019 our leak rates dropped below 10%. And the last 3 years, our leak rate has been 1 patient a year, averaging about 2%. We do about 50 to 60 esophagectomies per year. So we were really happy with these results. As a proctor, it also feels very good to teach a technique in which we believe ourselves. And these results really support our belief that this should be the way forward. When we have people coming over showing interest in minimally invasive esophagectomy, we always tell them about the structured training pathway that we developed as the early adopters, or maybe even the pioneers. And the first and very most important thing is that you have approval and support, both by your hospital, but also by your colleagues. The beginning of every technique involves a learning curve, and you shouldn't be put aside when your first complication occurs. So have approval, have support. For esophagectomy, we think it's very important to have a dedicated team of at least 2 surgeons that want to perform this technique and do it exactly the same. We have a team of dedicated anesthetists and nurses as well that really know how to work with the robot, but also really know what an esophagectomy is about. You have to have a sufficient caseload. as proctors, we believe that a minimum caseload of 20 esophagectomies per year should be sufficient for getting through your learning curve in an acceptable time. And of course, you have to have a guaranteed access to a robotic system, especially in your learning curve with all other specialties wanting to start as well. It can be busy on a robotic system, but you have to allow yourself and each other's room on space on the robot to be able to get through your learning curve and get the proctor in your house. The next step is to go to an expert center and see how other people have adopted the technique. And we always invite not only the surgeons, but also anesthetists and OR nurses, so they can look in their own field what's important to do in the robot around the patient and during anesthesia. And we show people how to prepare the procedure, how to position the patient, what instruments we use, etc. After that, and when the learning curve really starts, it starts with clinical training. There is an e-learning program, at least for the intuitive robot. I'm not using the other robots, so I don't know how they train, but they probably have an e-learning module as well. And in the e-learning, you can really learn, okay, what button is what kind of instrumentation do you have, how can I use the system? And once you know that, you can start your work on the simulator, first practicing basic skills, moving the camera around, switching your instrument arms, and then do some more advanced skills like suturing or even parts of a procedure. And then after this, you have to decide who's going to help you with your training and your proctoring. And for esophagectomy, for upper GI surgery, it's important to make a pathway, because going from nothing to a full esophagectomy in one step is too much. You have to decide, depending on your level of practice where you're at, if you want to do less complicated, shorter procedures first, or if you want to start with the esophagectomy, if you want to start with the thorax or with the abdomen. An esophagectomy is basically done in 3 different ways in the world. You can use a linear stapler, you can use a circular stapler, or you can do a hand-sewn anastomosis. And you have to find a trainer that's common with the technique that you want to use. And we all advise to stick with your routine technique until you have mastered all the skills on the robot, and then you can start to change your techniques according the way you want. And intuitive and also the community of the proctors that are there in Europe, they can help you to find the best trainer and to help you get through your learning curve. Usually this trainer does the training sessions with you as well. So we go to one of the European training centers, and there are many out there nowadays. First, you have your basic skills training. That's basically to demonstrate that you've done all your practice runs on the simulator. And then the next training is the TR200 training in intuitive. That's a procedure-specific training, and we do that for the upper GI surgery, especially for the esophagectomies. The first course is the abdominal course. We do Nissen fundoplications. We do a gastrojejunostomy. We can do all sorts of things that you will need for starting in the abdomen. And after that, there's an expert course for the thorax. And then the last step in your training is the clinical proctoring. So one of the proctors trainers will come to your hospital and help you for the first 3 to 10 cases usually. And then after maybe 10 or 20 cases, we advise you to do a revisit, so we can help you with tips and tricks once you are in the steep part of your learning curve. We advise all the procedures to be recorded, and the Upper GI International Robotic Association, UGIRA, has a data registry in which you can put all your cases and compare them to the rest of the upper GI community, which is really nice and very helpful. The UGIRA also organizes congresses throughout the world. Costs of the robot. It is a hot topic, but I always say, you know, if we started to give adjuvant immunotherapy worth 70,000 euros per patient, while there have not been published overall survival rates. We give proton radiotherapy, we give palliative immunotherapy. A robot-assisted procedure is about 4,000 euros more expensive than a routine minimally invasive surgery. The cost of a complication, a mild complication, is about 7,000 euros, and the cost of an anastomotic leak is about 35,000 euros. And when you see that our leak rate dropped from 20 to 2%, I think the business case is quite easy. So in conclusion, everybody can get started with esophagectomy when we have a well-organized training pathway, and in my opinion, the robot-assisted procedure really adds limited extra costs with a better oncological outcome and fewer complications. And besides that, and that has already been told today, it's also a platform for new innovations, ICG, augmented reality, etc. So it's really, in my opinion, it's really laparoscopy 2.0. With that, I would like to conclude, and I would like to invite interested people in our hospital to come and have a look. Thank you very much.
Thank you so much, Mark. We've got a few questions for you from the audience. What are your data or statistics on MI, stroke, and death in your upper GI surgeries?
We have a perioperative mortality of around 1%, and I'm not aware of the amount of MI, but it's really close to zero. I don't think there's a relation between MI and death, to be honest.
Thank you. Another question that's come in: are there prospects of the cost in robotic surgery getting reduced in the near future?
Well, I really think so, and I really hope so. It's still more expensive than a minimally invasive procedure. And a hospital can be very narrow-minded to just look at the expenses made inside the OR. The complete healthcare costs for treating esophageal cancer might even be reduced using a technique that reduces complications and maybe even improves oncological outcome. It's a very difficult, that's very difficult math. And usually hospitals are very compartmentalized and the expenses are made in the OR. And with all the new competitors on the market, hopefully costs will go down, and also the environmental footprint will go down. It does involve a lot of disposables. But this is only, even in intuitive, we are at generation 5 right now. And you know, the next decades, this technique will be improved and hopefully will get cheaper as well.
Thank you for that, because there are a lot more robots coming on the market, aren't there? Florian, I don't know if you wanted to add to that question as well.
Well, from a perspective of an hepatobiliary and pancreatic robotic surgeon, I can only agree completely, because I guess in the end, what we've seen throughout most of the studies, at least the retrospective comparisons that we've got, and that might also translate into the future prospective studies, is that with reducing the complications and the length of stay, and then actually even ideally including patients in ERAS programs, we can also reduce laboratory costs, etc. So in the end, I don't think that this is the major issue. I guess it's more a problem of availability and selecting the right cases for that.
Thank you. Thank you so much. What I'll do is I'll take one more question, Mark, because I know you have to get off. This is a question regarding what about lack of haptic perception when using robotic surgery?
That's a very good question. And in the beginning, this can be difficult. But when you're when you're through your learning curve, you really don't need the haptic feedback anymore. You can really, your eyes are really your haptic feedback. You can really see, because of the excellent view and the stable camera view, how much tension there is on your tissue or on your stitch. The next generation intuitive robot does have haptic feedback. I haven't tried it yet, but it's supposed to be pretty good. But to be honest, I really don't need it. When I'm in my console, I really can appreciate with visual feedback how much tension and how much force there is on my tissue.
Thank you. Florian, thank you so much, Mark, for your presentation and answering the questions. Let's hand over to Florian next. So, Florian's going to talk about robotics in hepatobiliary surgery. He's a consultant for HPB and general surgery and an assistant professor for surgical oncology at the Medical University in Innsbruck, Austria. He has a specific focus on minimal invasive surgery and all aspects of oncological care for abdominal tumor patients. So over to you, Florian.
Thank you, Afsana, and thanks for the kind invitation. I hope you can see my screen now.
Yes.
Okay. So these are my disclosures. I actually do have intuitive surgical shares. This is because I believe in the technique, and I think that this is going to be the future. I was asked to kindly present the evidence base for robotic liver surgery, which is, to be honest, not that many articles at the moment. So if you look at PubMed and search for robotic hepatectomy, per year, there will be recently about 170 publications. And this is basically all evidence from the intuitive Da Vinci systems. So when being asked whether there are any other robotic systems of relevance at the moment for hepatobiliary surgery, I can only say that I personally don't have any experience so far, although I know some colleagues are testing these new systems. But if you look for the evidence, for example, for the Hugo from Medtronic or for the Versius from CMR, there is no real evidence for liver surgery at the moment for these two systems. So when looking at evidence, it's always good to start with guidelines for robotic liver surgery. Especially, there are two guidelines internationally, which have mainly come from Asia, but also with some participation from Europe, US, and other countries. But most recently, that's a very interesting and ambitious project that I was lucky to also be able to participate, was the first internationally validated European guidelines meeting on minimally invasive liver surgery in general, which also covered laparoscopic. And as I hear, the manuscript is being prepared, and you will read some aspects about robotic and laparoscopic liver surgery in this soon, hopefully. So from the evidence, from the limited evidence that we've got, if you compare robotic versus open hepatectomy, as has been done in the surgical publication in 2019, which is mainly based on case series, and you will see that most of the studies will not have more than 100 patients. The one thing that we see is that the oncological outcomes are quite comparable to open hepatectomy. There seems to be reduced blood loss for the cost of an increased OR time. And there is a trend and also some statistical significance for mild and severe complications. And the length of stay seems to be reduced, which is been seen across all specialties in minimally invasive surgery. It's even more complicated, and there's even less evidence if you compare robotic versus conventional laparoscopic hepatectomies. So there's not many studies been published. One thing that the studies show is that the conversion rates are lower with robotics, as we've heard before from our colleagues from upper GI and colorectal. Also, blood loss seems to be less. There's no clear improvement in major complications, but this might change in the future. So in this Italian study, for example, they concluded that the main benefit for posterior and major resections is been given for the robot. So these complex operations might be safer with the robotic systems, whereas for the minor or more easy operations, laparoscopy should be good enough in some cases. And then very recently, I've found a study from China which compared robotic versus open surgery for simultaneous resection of, for example, rectal cancer and liver metastases which can be considered quite a challenging simultaneous operation. So this is the first randomized controlled trial, and they showed that robotic surgery has better short-term outcomes in reducing complications with similar long-term oncological outcomes. So far, no real translation into long-term oncological outcomes, but if you look in the right lower corner of the study, for example, you will see that the time to start with the adjuvant chemotherapy is lower after robotic compared to open surgery. And that is something that has also been shown, for example, in the orange trials. This is the orange +2 trial, which compared open versus a minimal invasive, in this case, laparoscopic hemihepatectomies. And they showed that on average, patients will receive adjuvant systemic treatment 2 weeks earlier, which is basically a surrogate parameter and a result of improved quality of life after minimal invasive surgery. So more recently, also, there have been several publications by large international data groups, such as this one around the group from Brian Goh from Singapore. And they've also now looked at more difficult resections from the posterior and superior liver segments, which are segments 4, 7, and 8. And they also conclude that in the end, the duration of the operation is actually lower for robot compared to laparoscopic. The blood loss is lower, the need for blood transfusion is lower, and also the conversion rate is significantly lower, with about 1% compared to about 8%, which then leads to a lower length of stay in some cases. And when being asked about what is actually being done robotically worldwide, there is not a huge amount of data recently on large scale publications, but for example, this one from 2020 summed up the evidence until 2019. And as you can show, there's quite an increase in the numbers overall, but still up to 2020, most of the procedures were wedge resections, segmentectomies, or unspecified other minor resections or left lateral sectionectomies, mostly for hepatocellular carcinoma and colorectal liver metastases, or benign. So in the end, not many people are, for example, operating on hilar cholangiocarcinoma with the robot, which is extremely difficult, and other very complex cases. But there are centers that are now trying these indications. So this is a very interesting survey. It shows that around 120 surgeons from 103 centers in 24 countries, about 30% of all of the operations were being done minimally invasively, and laparoscopic is still twice as common as robotic. So just a quick take on how to start robotically. Selection is key, in my opinion. This leads me to the first topic of the team setup. I can only encourage you to read, for example, these publications from Utrecht or from Seoul or from Modena, which also all described how to set up a team and how to reduce the learning curve, so you don't need to invent the wheel completely new. My personal experience is that if you have an expertise in open liver surgery and ideally in minimally invasive surgery, even better in minimally invasive laparoscopic liver surgery, you should choose at least 2 surgeons, as been said before. And also it's very important to have at least experienced scrub nurses and technicians in liver surgery, ideally scrub nurses that have an interest in technique and laparoscopic and robotic surgery. And also anesthesia and ICU care is very important for their first cases. Then the question is always which cases to start with. One thing you can look at is difficulty scorings. So it's very important to start with low difficulty cases, such as defined by the IVATE score, cases in segment 3, segment 2, segment 4A or 5 or 6, small tumors, no major vessel involvement, no cirrhosis, etc. And this will lead you up to the ladder of expertise with very high expertise cases, such as right to left hepatectomies or posterior sectionectomies. This is a good tool to estimate the complexity of liver resections, but it has been developed for laparoscopic, and this might be a bit different in robotics, to be honest. This is very interesting and a very important publication from the Charité in Berlin, where they've shown that compared to previous reports, that the learning curve is probably sufficiently been come, about 20, 30 procedures, they do not agree. They think that there is a second learning curve, as been described by Professor Khan as well. If you take on more complex cases, after 50, 60 cases, you will get into complications. So you will need to readjust and slow down your techniques in order to become proficient after about 100 resections. So this is quite a high number that is necessary in liver. So this is a good case to start with. That was actually my first case in my previous hospital, together with Stefan Stettner, a colleague of mine. These are more complex cases that you can do extended left resections for, in this case, a large, very symptomatic but benign tumor. And what to expect if you start operating with the robot. So basically, this was an analysis of 50 cases that we've done. It was about a year ago. The median blood loss was 200 mils. The conversion rate to open surgery was 4%, which was much lower than before with laparoscopic, where we had about almost 20% of conversion rates recently, and the length of stay was about 4 days. More recently, we've shown our data on the ESSO Congress, and this is a paper I'm about to publish. So what happens if you implement a robotic and also an enhanced recovery program, an audited official ERAS program in an established liver surgery unit? It improves a number of perioperative outcome metrics. So we have compared 3 different eras. The first period was before implementation of robot and before ERAS certification. The second period after starting robotics, we had an ERAS-like program where we started implementing different key items of ERAS. And then we did the certification, and the third period was robotics and ERAS fully implemented, about 1.5 years. So these are the numbers. So altogether, it's more than 220 patients. By the end of this study, we had done around 60 to 80 patients per period. The characteristics were quite comparable through the periods. And this is interesting. If you implement robotics, you can significantly increase your number of minimally invasive surgery, despite having done laparoscopic surgery before. So that in the end, we had about 80% of minimally invasive surgery, and half of the patients who have been done robotically, and with about 30% major resections. Obviously, the operative time increases in the beginning, but the blood loss goes down and the blood transfusion rate goes down significantly. So that in the end, only about 5% of patients needed blood transfusions. This was also simultaneously with an ERAS implementation program, as I said before, and you can see that with the official ERAS program, all aspects of pre-admission, preoperative, intraoperative, and postoperative ERAS item compliance increased to more than 80% compared to about 40% before. And with this, this is so to say the summary slide for this own data. We decreased our length of stay from 9 to 6 to 5 days, our intensive care stay from 3 to 2 to 1 days. Our textbook outcome of liver surgery achieved data about 70%, and we had less complications, severe and over complications. Just a tiny glimpse in the future. So I think that fluorescence guided surgery and augmented reality, as been shown by Professor Khan already for colorectal, is the future in liver surgery as well. You can use ICG, indocyanine green, for example, for cholangiography, for tissue perfusion. It's been shown in the left lower picture, and also for tumor detection if you give it a day or more before surgery. But in the future, there will be other fluorescent dyes, not only ICG, but other dyes that might be tumor-specific, CA-specific, CA19-9-specific. So you can also dye different types of tumors, etc. This is a very interesting study from the colleagues from Leiden, from the Netherlands, which are real experts in fluorescence-guided surgery. They showed that if you inject ICG on the day before for colorectal liver metastases before doing liver resection, you can increase historically reported R1 resection rates of about 30%. If you don't leave any green ICG positive tissue behind. And they published their results in JAMA Open very recently. They've shown that with this technique, you can increase the R0 rate about more than 90%, and about 1 in 5 patients, there will be a change in surgical plan due to additional lesions that you find, or more extensive involvement of the liver than you would expect. So finally, just some short video cuts. This is our common OR and trocar setup. So we have the patient's leg spread, so French positioning, and the head is a bit up 15 degrees. We usually use a laparoscopic 12 millimeter insufflation trocar at the umbilicus and have 4 trocars above in a very straight line. You can adjust according to the case. And then usually we use a fun and steel incision for the retrieval of the specimen in the bag. So this is a short video that sums up most of the techniques that I've described. So first of all, it's a patient who had a history of colon carcinoma and had a liver lesion. So we all expected this to be a metachronous solitary liver metastasis. In the end, it turned out to be an HCC, interestingly. We've given ICG on the day before, and now I'm doing the intraoperative robotic ultrasound, which is an excellent tool to delineate any anatomical structures and the tumor. And if you combine now the ICG application, fluorescence, guided surgery with ultrasound, this becomes highly precision surgery. So in the end, you see the inflow to segment 3 and segment 2, and then you can start after demarcating your planned resection line with the surgery. We usually have 3 robotic instruments, of course. This is, for example, an intracorporeal inflow occlusion. It's called a Pringle maneuver with a Foley catheter. And if you see that it's bleeding too much, you can just apply the Pringle. We are in the area of the left lateral sector. So basically what you see is the teres hepatic ligament or the falciform ligament. And we're extending the left lateral resection a bit to segment 4E because of the involvement of the tumor. So now I'm just starting to cut incise the liver, just cut open the liver surface, and then we are actually applying a very historic and old technique, which is called the crush clamp, to go through the liver. This is now the pedicle and the inflow to segment 2, so you can see that you can apply precision to vessels and bile ducts as well. We usually use a laparoscopic suction. That is also useful for dripping some saline on the resection margin, so it's not sticking to the instruments. As you can see, with the Pringle on and also with recording an appropriate anesthesia, there's almost no bleeding. So this is considered to be one of the more easy operations robotically, and this is just to show you how you can apply the ICG if you're not sure intraparenchymally whether you are safe away from the tumor. Again, I'm doing some crush clamp. I might advance a bit. So this is a laparoscopic stapler now. You can use laparoscopic or robotic stapler for the inflow, for example. On the right, you've seen the tumor, which we are away from. And then again, I'm doing more crush clamp. And a very good tool is the robotic, these clips. It's a Hemolock clip. So you can angle them around, which is a difference to the traditional laparoscopic ones. So these are more precise. The same with the scissors, you can angle them. And then if you continue more towards the back of the liver and to the cranial sections, you will come to segment 3 again. You will see how precise, even with small, tiny holes in the portal veins or the liver veins, it's very easy to control bleedings, very easy and very precise to apply the clips. And then the very end of the operation, we are approaching the liver vein. It's the left liver vein. Even there is some bleeding, there's no major blood loss. And with the laparoscopic stapler, we are good to go. And that's the end of the operation. A tiny clip at the very end just to be safe. And we put the specimen in the specimen bag, and that's it. So if you're interested in learning more about this type of surgery, especially hepatobiliary surgery, liver surgery, and robotic surgery in particular, I'll invite you to come over to the Innsbruck Medical University for the hands-on course on liver surgery done by ESSO and ESEC, which will take place on the 7th and 8th of April next year. And we are planning to implement robotics more in these courses as well, but also laparoscopic and open surgery for basic and advanced participants. And one thing that I always personally like to recommend is freely available sources such as YouTube videos, especially from 2 colleagues, Jason Hawksworth from the US and Mathieu Don from Belgium. They've been so kindly enough to share all their expertise with hundreds of videos, which are brilliant. And there's only so much that you need to learn many things about different techniques. So, but most importantly, I can only encourage you to enjoy surgery, because operating with the robot and also liver surgery in general is really fun most of the times. So I'm happy to answer any questions. Thank you.
Thank you so much, Florian. That's absolutely fantastic. Such a large topic that we've covered today and 3 main specialities. At this point, I'd like to invite Ruth back as well. So let's go through some of these questions together. Some questions directly to you first, Florian. How is the training for robotic surgery and hepatobiliary feasible if there are mostly complex cases done?
So I can tell you from my own experience, the way I learned it is I started with open surgery, obviously many years ago. I'd say liver surgery about 10 years ago. And then I've started doing laparoscopic surgery, laparoscopic liver surgery during a fellowship in the UK, quite similar to Ruth. I've been to Liverpool. So this helped me to understand the basic concepts of minimal invasive liver surgery. So this is quite comparable between laparoscopic and robotic. So whenever you've got the chance to do minimally invasive surgery, anything, and that might be cholecystectomies or tiny liver cases, that is of help. And then with robotic surgery, it helps to divide these cases into tiny modules. So one surgeon, for example, can mobilize the liver. The other one can start the parenchymal dissection. And if it's getting more complex, the more experienced surgeon can take over, especially with a dual console, as been shown before. But a fellowship, I can only recommend.
Ruth, I'd like to bring you in at that point as well, because you're doing a fellowship currently. So what's your comment on the same question?
Well, I will say the same as Florian. Right now, I'm mostly focusing on liver transplant, so not too much exposure to robotic at the moment. Though in the center they are doing robotic surgery, and I will say the same. And for any other super specialty, it was the same. You need to start by the simple cases or the steps in the surgery that are easier for you when you start learning how to use how to do this procedure in liver or in colorectal or in upper GA. And by the way, when you are learning these skills and gaining further exposure, then you are able to do more complex things.
Okay, thank you. And Florian, I've got a follow-on question here from someone. How about the learning curve in robotic hepatic surgery?
Well, as I've briefly touched on in my presentation, I think the publication from the Charité group in Berlin is really excellent to read through because of the discussion and introduction. It says a lot about learning curve. My personal experience is that you will have a sort of a proficiency after 20-30 cases. So you feel safe. Then if you do start right hepatectomies, for example, and if you embark on large tumors, the learning curve is quite long, and I think it will take you actually for your whole lifetime to master these things, as usual in surgery. But I would expect to do at least 20, 30 to 50 cases to be somewhat stable for major resections.
Thank you. I've got another question. Do you have limitations to robotic instruments in parenchymal transections?
So this is a very common question in the liver surgery community, and the same as the one below, who's a liver transplant surgeon and uses CUSA. So I've been trained to use CUSA a lot as well, especially in laparoscopic, but I was forced actually to use the crush clamp technique because our CUSA wasn't working properly in the beginning. And then we found out that the crush clamp technique is actually, in my opinion, much better. It's easy, it's cost affordable, and in 99% of the cases, it will do the case. From time to time, I use SynchroSeal, for example, which is one of the energy devices. It's got a tiny tip and you can do crush clamp, but you can also seal. But overall, there will be people like Luca Alderighetti from Italy that barely use anything else than crush clamp.
Thank you. Ruth, I've got a question for you. I know we touched upon this about haptic perception, and it said, what about lack of haptic perception? As a trainee, I know you've had some experience in robotics, so I'd like to have your comments on that as well, please.
Yeah, I would say that this is something that have already been touched by some of our speakers today, but essentially you need to learn the skills as well of how you can compensate this lack of uptake with other things, like you have the 3D view that you don't have in laparoscopic, for example. So you are able to see how deep the tissues are, to see properly how much are you pressing with your forceps, for example. So you compensate this lack with other skills that you learn by the way. So yeah, it's true, it's a limitation, but you compensate by the way. So
Thank you.
but it's something that you need to train, because it's not easy at the beginning,
Thank you.
and it can be dangerous in some cases.
Thank you so much. And the next bit I want to carry on is, which route is better for a newly trained surgeon, because we're doing training at this bit, mastering the laparoscopic followed by transition to robotics, or directly going to the robotics training? I'll ask you first, Ruth, and then I'll go on to Florin.
I would say that this is quite controversial actually, because there is some published data and there is studies saying one thing, and then there is studies like saying that it's the same. I would say that it depends as well on what's your exposure and what you can access in your center. In terms of, I'm sure that having laparoscopic skills help you as well to do robotics in some way, but it's not essential. I know many surgeons that have gone directly to robotic without having mastering laparoscopic is possible. But again, I'm sure that all the skills that you have in minimal invasive surgery can help as well.
Thank you. Florin, if I could turn to you, if that's possible.
Yeah, again, I fully agree. One experience that I made is that if you start, for example, with laparoscopic liver surgery at least, and then you start with robotics, your skills in laparoscopic surgery will increase as well, because you get a different view of things. You experience more detail of anatomy and try to be more precise. And when you're more precise with robotics, you try to be more precise with laparoscopy as well. So in an ideal world, I think that you could do both actually, because there will be cases that will benefit from laparoscopy, like a left lateral resection. There's no need actually to do robotics, although it might be better and more precise. And then there will be days when you don't have access to the robot, or the robot will fail, or you will need to do some steps of the operation laparoscopically because of adhesions, or any tool doesn't work, or you don't have access around the corner, whatever. So basically, if you can, try to train both in parallel, if that's possible. So you can do some cases laparoscopically, in some cases robotically, and then in the future, this might all change and everything will be done robotically, I guess.
Thank you. And Florin, I wonder if you can pick up, there's about 3 different questions there, if you could combine them together regarding the HPV and answer them together, if that's okay.
Well, if I find them, so there's one, do you use SynchroSeal? So as I said before, I from time to time use it. It seems to be good if you need to speed up a bit during parenchymal transection, but sometimes the tissue sticks to the SynchroSeal in the liver. It's not ideal in some cases. Then the other question was, you said you use laparoscopic suction. How does your assistant fit and how is his ergonomics? So that's an issue. First of all, the laparoscopic suction will be inserted into the umbilical port. Some will use a bit of a lower laparoscopic port or a paramedian port, especially for these reasons, so that you can access more easily. There will be always a bit of a fight for the on-table surgeon, to be honest. You have to really watch out not to be hit by the robotics arms. You have to have a suction that is long enough, especially if you do, for example, a right hepatectomy, to be able to do the suction up at the upper abdominal quadrants if there is any bleeding from the hepatic veins, which can be very dangerous. So ergonomics is not ideal, honestly. There is a robotic suction tool as well, but if you use it, you lose one arm that you can use for retraction, etc. So this is some room for improvement for sure in the future, but it's doable. Honestly, many people are doing it for hundreds of cases. And it's nice also for the on-table surgeon to be involved in the operation rather than just sitting around and changing the instruments.
Thank you, Florin. And the other question is, do you use staplers or clips for parenchymal and vasculature?
Well, whatever is necessary. So for most of the vessels, arteries and portal veins, etc., and even sometimes for smaller liver veins, I will use Hem-o-lok clips. They are very precise to put them on, and also they're not too large. If you use staplers, you sometimes have the issue that they are too large to, for example, get across the portal vein. And then inside the parenchymal transection, it really depends what type of operation you do, but most of the times I will do crush clamp, and then if I see any structures, I would try to, first of all, put a clip on. And then sometimes you run into trouble during operations. It starts to bleed and you think, okay, you've put on Pringle and more Pringle and more Pringle, and you just don't continue enough per time to be sure that the patient is being well. So sometimes you need to end up doing stapler hepatectomies, like the Heidelberg group, for example, describes. So at the end of for example, segment 6 or 7 operation, sometimes we need to use 3, 4 staplers just to end the operation and put on some gauze and then take care of the bleeding. So in the end, ideally, you have everything available, honestly.
Thank you. And we've got a question regarding what is the evidence of robotics in breast cancer surgery? So I know none of this webinar didn't cover the breast as a speciality, but I wonder if we can cover some of the advantages of the robot and how that would transfer. So maybe Ruth, if I go to you first.
I don't have experience with robotic in breast cancer, but I know that the ESSO organized a specific webinar for robotics in breast cancer recently, so I'm sure that they will be available in the website at some point. I know that it must add the thing that we have already been saying with other subspecialties like the precision surgery, like being minimal invasive for breast cancer, but I'm not sure about the evidence in terms of oncological outcomes.
Florian, would you like to add anything to that?
Well, I personally have got no experience with robotic breast cancer surgery. There's also certain types of specialties like thyroid surgery, where, for example, there's transaxillary or transoral access. This is mainly due to cosmetic issues in some, and also cultural topics in some countries, like in Asia. I think the main benefit in these things might be nerve identification, fluorescence, application for sentinel lymph nodes, etc. But other than that, I don't think that there's much evidence. The evidence is, I'm pretty sure, even less than in liver surgery. So I think you need to go to very specialized centers in order to have a chat about this. Yeah,
and there's a few references that have been recently published in the chat as well. And there's some, I know I need to bring this to a close now because we have run over time. But there were really interesting questions, and I'm really grateful for everyone who's answered the questions, and we've tried to answer as many questions as we can during the session. Please do go to the ESSO website, which I sent earlier regarding the courses, because there are, as Ruth mentioned, quite a lot of different courses for the different specialities. So basically, we encourage you to do further reading and look at the ESSO website for further courses. Look at the ESSO Congress, which will be happening in October 2025. And as Florian said, you do have an opportunity to submit your abstracts and to actually present them at the Congress. I've put the links in the chat. And this year and last year, there was a robotic session, which is always interesting as well. So do look at the programme. Thank you for the wonderful panel who have made this webinar possible, Maria and the ESSO team who have supported us to make the idea a reality. I thank Ruth and Florian especially, who have spent many hours working with me to pull this webinar together, and it's a real team effort. And I thank you as the participants for joining this, and I hope you have been able to sort of learn more from our knowledge and have more discussions in the future. And hopefully we'll see you again at some more of the webinars. Thank you so much.
Thank you all for organizing.
Thanks.
Have a nice evening.